The next mode that I'd like to demonstrate on this defibrillator is pacing mode. So this is for our bradycardic patients. The difference with this mode is that you need pads and the 3 leads on the patient. If you don't have both sets on, you will not be able to pace. So the machine monitors the rhythm through the 3 lead and then delivers the current through the pads. So unlike cardioversion, where the pads can just deliver the current, in pacing you need both sets. The pacer function is the last point on our dial. So we need to come all the way around to pacer. And then at the bottom here, you'll have a flashing sign that says start pacing. Follow that down and push the soft key, and that's the first thing we need to do. That will then reveal our pacing spikes across the screen. Now we know that in pacing, what we need to achieve is a QRS complex directly after every pacing spike. So in terms of rate, our defibrillators at Medway are set to a rate of 70 beats per minute, and that is adequate for most of our patients. You certainly wouldn't want to be going much higher than that in these patients that are unwell. What we do have to change and increase is the amps. That's the energy that's going to be delivered through the pads that will allow for mechanical capture when we're pacing. So we're going to go to pacer settings, hit the soft key. We don't want to change the rate, so we're going to use the dial here to change the output. Press OK, and then we will dial up. You can dial up in 5s and increase it gently or slowly. Depends on your experience with doing this and obviously for the comfort of your patient. But typically, just through experience, you're unlikely to capture anything under sort of 70 or 80 milliamps. Once we get to the energy we want, we select, and then we will look to see if we have what we would refer to as electrical capture. That means a QRS complex after every pacing spike, which I am confident that we have achieved. The next important thing, once we've got it on the screen, is that you go back and you check your patient. You check that they've got a regular output that correlates to what we're seeing on the monitor, and we would expect to see some improvement in our patient and improvement in blood pressure. Once we have this capture, this is a very temporary measure that we're doing for our patient. This is certainly not a long-term solution. This is just buying our patient time until we can get a pacing wire or a pacemaker fitted. So over time, patients will lose tolerance to this type of pacing. So as an insurance policy, once we've got our initial capture and we're happy, we will then increase it by another 10 to 20 milliamps. So same principle. Go up, press OK, and then of course go back and check your patient again. If at any point you want to pause pacing, you want to see what the patient's underlying rhythm is, we can do that by pause pacing, same button. It will ask if you are sure that you want to pause pacing. We'll dial to yes. And it will show us what the patient is doing for themselves. Still bradycardic, still has a need for pacing, in which case we resume pacing and it goes back to where we were before. And of course, go back and check your patient. So the next thing I'd like to show you about this model of defib is its other capabilities, and one of the other things this machine is capable of doing is cardioverting a patient that's in a tachyarrhythmia, commonly VT or an SVT. So in order to do that, we must have the pads applied to the patient. Now these can be applied in the traditional way following the pictures that are on the pad. However, this patient is still alive. As we say, it's a cardioversion, it's not a cardiac arrest, and the alternative pad placement that might be better is an A and P pad position, so in the middle of the chest and then mirrored at the back between the shoulder blades. This sometimes means that there's less impedance across the chest as the pads are closer together. And obviously this is easier to do because our patient is still cooperative with us at this time. So either is fine, but the pads must be on the patient's chest and the patient given some light sedation because this is going to hurt. So to cardiovert your patient, it needs to be a synchronized shock. That means we deliver the shock at the same time as the R wave in the rhythm. Don't be too concerned about that, but the sync button is the important thing, and it is here. We must ensure that this button is on. The risk, if we do not put the sync button on in this type of patient, is we may shock them into a worse rhythm. We may shock them into a VF and make the situation worse. So this is really, really important that we activate that button. The button will glow blue, and what you'll see is little arrows coming across the screen. And so those arrows are finding the R wave within the rhythm so that the machine will coordinate a shock at that point. You'll also see in the corner that it's flashing with sync. So we know that we're safe and we're ready to cardiovert. The energies we use in this truss, regardless of whether it's a broad or a narrow complex tachycardia, is that we do the first shock at 100, the second shock at 150 joules, and the final shock at 200 joules. We dial it round, so we'll deliver our first at 100 joules. We charge in the same way. Everybody should be away from the bed. And then we deliver the shock. This is slightly different to our cardiac arrest management in that when we deliver the shock during cardioversion, you need to hold that shock button for slightly longer so the shock can be delivered at the R wave.
Shock delivered.
Once we've delivered the shock, we go back and we check our patient, and we carry on with the second and third shock as required. Like I say, 100 joules, 150 joules, 200 joules. In our trust, once you apply the sync button, that will stay on for all of your subsequent shocks. If you need to then shock your patient because they've gone into, say, a VF, you will need to remove that sync button then in order to deliver that shock.